Good morning, everyone. Come in, grab some breakfast, take a seat. Please, we want to make this a comfortable space, so please feel free to, get up, get more food, get a drink, whatever, throughout. But thank you so much for getting up so early this morning and coming to join us for our breakfast session. It's a real honour to be here with you. Before we begin, I, of course, would like to acknowledge the traditional custodians of this country that we're meeting on today and pay our respects to the Wurundjeri Woiwurrung people of the Kulin Nation and, of course, pay our respects to elders past and present. We also acknowledge any other First Nations people who are here with us today. We know there's quite a few of you at this conference and a strong theme around Indigenous health and excellence within this conference program, which is so great to see. It's a real honour to be gathered here this morning on the banks of the Birrarung or the Yarra River, and we'd also like to acknowledge that powerful welcome to country that we witnessed yesterday from Dr. Mandy Nicholson, and her reminder to us all of the power of country to heal and to hold us, and we hope that we all feel that this morning in this session as well. So we're very excited to have you joining us. Our session is around sharing stories of First Nations excellence, lessons in partnership, sustainability and impact. And we're here representing our amazing Guunu-maana Aboriginal and Torres Strait Islander Health Program, which is part of the George Institute for Global Health. So Guunu-maana means heal in Gumbaynggirr language and really represents the way that we work and the focus of the research and the broader work that we do, which is very much centred around healing. And we're incredibly grateful to be part of this program for the Regional World Health Summit and really for the opportunity to put Aboriginal and Torres Strait Islander community-controlled strengths and Indigenous-focused health services, models and impactful research onto the global stage. So we really thank the conference organisers for allowing us to be part of such a strong program. As I said, we want this session to be really conversational. Anyone who knows any of us will know that we like a good yarn, particularly Telfia and Jamie on the end there, who we've brought along. So really encourage your participation as an audience. Please don't feel too shy to ask questions. We'd really like you to feel welcome to ask anything of our amazing panel here as well. But before we go too much further, you're probably wondering who each of us are, so we'll just do some brief introductions. So my name's Kezia Bennett-Brooke. I'm a Torres Strait Islander woman. I grew up on Dharawal country and still live there just south of Sydney. I'm a mum and I am Program Head of Guunu-maana Heal Aboriginal and Torres Strait Islander Health Program at the George Institute. And I'll hand over to you, Jules.
Okay, that was a little bit hard. I didn't know if it was on or not. Julianne's my name. I'm a Gumbaynggirr woman. Grew up in a little tiny country town, Walgett in New South Wales, Camilla country. I am a mother of 5 daughters, 14 grandchildren and 2 great-grandchildren. And it's a pleasure to be here.
And I am Kate Hunter. I'm a non-Aboriginal woman of Irish descent. I don't have as many... When we're thinking of family and who we are and our connections, I have 4 children but absolutely no grandchildren. Okay.
My turn. I'm Telfia Leanne Joseph. I come from Western Australia. I'm a Yamaji Wadri Noongar Whadjuk woman. But I've been on the east side of Australia since I was 18 and decided to get away from my mother, who we have a beautiful relationship now. But I work in the Safe Pathways position as the Aboriginal health worker, and I'm very lucky to be a part of the Guunu-maana team that have literally adopted me. It's fantastic.
Good morning, Jamie Newman, CEO, Managing Director of Orange Aboriginal Medical Service. It's our 20 years of operation this year and I've been there since we started. Great to be part of this team and sharing with you today, hopefully, of the impacts that solid relationships can have for our people and our communities. I'm a Wiradjuri descendant. I'm not a Wiradjuri elder. I'm older. There's a massive difference. I still have aunties and uncles and older people that I've grown up around that are elders to me. So me saying I'm an elder, I'd get slapped silly. So I'm very careful not to say I'm an elder. A lot older, but not an elder.
Thanks, everyone. Let's see if I can get these slides working. Okay, so we just thought before we get into the panel aspect of this breakfast that we would tell you a little bit about our Guunu-maana program and our model of working to really set the scene of who we are and how we work. So there's some wording there on the slide which comes from our team vision statement. And so we're really led by and for Aboriginal and Torres Strait Islander people to generate evidence that privileges Indigenous knowledges. And so much of the work that we do really unpacks questions around whose knowledge counts and about what it means to work at the interface of different knowledge systems. And I think that's really been permeating conversations that we've heard through yesterday as well. Something that we also heard yesterday was discussions around evidence generation and how we measure success, what indicators are, and what are we measuring and for whom. It was also noted yesterday that knowledge coming out of communities is not recognised enough. And so this is really centred in our way of working, and in everything that we do, we really maintain an Aboriginal and Torres Strait Islander holistic definition of health and healing. And that includes health as being really inextricably linked, not just to ourselves, but to each other and our communities and to country. As you can see in the diagram here, we have our knowing and our being and our doing at the centre of everything that we do. And even though we're situated within a global health research institute, we do so much more than just research and knowledge generation. So just as importantly is the work that we do in capacity building, and that's not just of Indigenous peoples, but really importantly doing a lot of work around building capacity of our non-Indigenous allies, and also of the organisations and structures within which we work or those that we collaborate with as well. We have a strong focus on advocacy and impact, really seeking to speak out on important issues and supporting communities and amplifying the voices of those that we work with and those key messages, and really leveraging the structures that we have, and the stakeholders that we have within our organisation and across our global reach as well. And then absolutely critical is our partnerships, and that's going to be a strong focus of what we're talking about today. So we'll hear more specifically from Jamie and Telfia in relation to those partnerships. Jules, I'll hand to you to talk a bit about our way of working.
Okay, thanks, Kezia. Did you hear me dreaming last night? We are going to talk about the way of working, but I just wanted to say what really touched me yesterday was Mandy and how she said that we've lost a lot of our language, and just to speak one word here and there is bringing it back again. So, Ginagay, everybody. Hello. I also think that there's a lot to say about our stories that should be passed down through the generations as well. And I can only speak of my part of Darkinjung country and North Sydney, Central Coast area. But an elder had taught me about the Bora circles and how the Bora circles in the sacred sites, there's over 10,000 just on that section there. And the Bora sites were where families, and we're not talking 14, we're talking 40, would gather around and do learning and sharing, and that's where they would do ceremonies and initiations to become elders of our communities. And you didn't have to be an old person to become an elder. You could be 30 and be an elder. So I also am not an elder. People do call me auntie. I'm quite happy to be auntie, but I'm not an elder. So having said that, I just think our way of working represents what we've already been doing for thousands and thousands of years. We've been asked by, our organisation, like, how are you going to keep this going? You know, the more people that you get, the more researchers you get, how are you going to keep this going, your team? And that's what made me think back to the families and the Bora circles and gathering together, and the jajams, the little babies, and looking after them, and then the aunties and uncles would also grow up, the young boys and the young girls, and they'd have their own sacred ceremonies. And then you'd have the aunties and uncles who would then look after the auntie and uncles and the grandparents. And there was always a job for somebody to do, but it was always connected. They were always connected. They were always supporting each other and growing each other to come to that point where you could become an elder. So I just look at our team and I see that with us. We, you know, the young researchers that have just come on board, our jajams, you know, like the aunties, the senior research fellas, and our elders. And I'm not saying Kezzy's an elder, but she takes that place in the Guunu-maana team. So I know it says that's our way of working, but I wanted to explain it in our ways of knowing, being and doing. So, yeah, so now I'm going to just hand it on to Kate to talk about some of our projects that we are doing. And I just want to remind you that with our way of knowing, being and doing, how we started this was listening to the voices of the families of children who had sustained a pretty bad burn injury. So everything that we're doing in our programs are already coming from the ground up first. So we're listening to our communities, and that's what you do when you're in community. You listen, ask what they want, and then we go ahead and we do it. So, and then Jamie can also speak to that as well. So, Kate?
Sure. Thanks, Jules. And so, following on from what Jules was saying with listening, Jules spent a lot of time yarning with families whose children had had a burn injury and hearing their story, hearing where the gaps were in care. And from that, we have developed 2 projects that we're using as a case study today. And throughout that, as you heard both Kez and Jules speak of country, connection, relationality, and of course we heard a lot yesterday, trust. And so with these 2 projects that are all around improving burn care, we're bringing safe pathways, as Telfia has said, which involves an Aboriginal health worker who is dedicated to the burn unit at the Children's Hospital at Westmead. Included in that program is a Building Cultural Safety and Capabilities program where we work with this multidisciplinary burn team and deliver a program over several months to improve their understanding and ways of working alongside and with Aboriginal patients. And then the final component, which is where Jamie comes in, is connecting with community. We also heard from families that there was a big gap, that once home, as far as the connection with the services, the mainstream services weren't automatically connecting with the Aboriginal Community Controlled Health Services, and yet we know that Aboriginal Community Controlled Health Services are points of trust for people. And so we also heard that there was a gap in opportunity of burn training, that previously it hadn't been offered to Aboriginal medical services in New South Wales, and so we connected with the statewide burn injury service and are delivering a burn care program with Aboriginal Community Controlled Health Services across New South Wales. And so with that, and you'll see in that diagram, there's the jigsaw puzzle, and it's really all about filling all the gaps and creating a holistic picture of burn care. For our focus is on Aboriginal children, but we hope that, of course, this process and model can spill over into other areas.
Thank you, Kate, for setting that scene of what we're talking about today. We're going to jump into some questions for the panel, but we're just going to keep this slide up here. If anyone has their phone handy and would like to follow us on social media. We're trying to grow our following and have been given strict instructions from other members of our team to share this today. So if you'd like to, you're more than welcome to. But I'm thinking I might actually start with a bit of a contextualising question, both Telfia and Jamie. I'm conscious that we have an international audience here. And maybe you can speak to, Jamie, first, what does the Aboriginal community-controlled health sector look like, and what is the spirit of that? What does that mean? And Telfia, maybe if you can talk about the role of Aboriginal health workers. Yeah.
Thanks, Kez. If anybody in the room knows what the definition of Aboriginal health is, this interaction, right? So if you don't know, it's okay. But it says, this is from 1989, not just the physical and emotional well-being of our people, but our social, cultural and spiritual well-being of our families, our communities. We have to practice that. If we're ever going to get health outcomes for Aboriginal and Torres Strait Islander people, we have to practice what our definition is. For the last 19 years, we've been reactive to illness and disease. Yet the first Aboriginal medical service in Australia was set up to prevent illness and disease. But we're still reactive to it today. 19 years have closed the gap, and we're on target for 2 out of those 7. So the government, in their wisdom, add 8 more. No more new funding, but 8 more new targets. That's a challenge. It's not a threat to us, it's a challenge. What has to happen for us is that we have to be more receptive to research as Aboriginal community-controlled health services. Evidence-based practice is what will get us health outcomes. Working with people who understand how to collect data, analyse data, and then put that into practice for us. We know how to deliver it, but we don't have the expertise in our organisations to plan it and to analyse it and say, this is how you can do it. So it's critical for us to have this relationship with our universities. As I said earlier, we've been around for 20 years. We have a relationship with 5 key universities. It's mainly around research, about clinical practice, about knowledge and understanding. I believe co-designing has to happen with the key players that are involved in health. Not so much with our communities. Because I could ask anybody in this room, how do you navigate health systems? And you'd probably struggle telling me, how do you navigate health systems? I've been in the health system 25 years, I'm still struggling to navigate it. So if somebody who's entrenched in the health system doesn't know how to navigate it, then our people struggle day to day. The beauty of this partnership is that we have a link not just locally, but to Westmead. So when we have tertiary issues in our communities, we've got a pathway for our people. I'm sure Telfia will be able to expand more on that for you. But for us, it's if hospital systems are the go-to, and our history tells us that there's massive breakdown with our people accessing hospitals, then our people are going to suffer even more. The other consideration for us, we're not just a medical service, even though I love the medical element of what we do. We're an out-of-home care provider, NDIS provider, and an aged care provider. Not residential aged care, but more connecting older people to aged care services. The crucial thing about having this program and having a burns care project within our Aboriginal medical service, especially around our children, is there are perceptions and views when our people present at hospital with a child who might have suffered a burn. We've learnt through being in the out-of-home care system, and if we talk about reform that needs to happen in our old systems for us to get health outcomes, if our children are still being removed because of a burn, then we've got problems. That's why we need to be the driver of healthcare, especially around burns care for our people, so that they're not afraid of presenting to health systems with what is a burn. I've learnt, even in the short time we're working with these guys, how many ranges of burns there are. And more importantly, what happens when we don't treat them right. So for us, it's about building our capability and our capacity to be able to say to our community, we can provide care for you, for burns care. We can be the driver. It enables us to build a more stronger relationship with our acute system, builds our capability and allows us to be the safe provider of healthcare for our communities. That's crucial if we're ever going to get health outcomes for our people. So we don't, and this might be contentious for some people, for our mob in the room, but I don't believe we have to co-design with community. Communities are the recipients of what we do as a collective. Our community needs to see that we're working with everybody in their best interests. System reform, where we're talking about closing the gap, is the gap that exists between the providers who are there to provide healthcare for our people. So we can work with universities, mainstream services, even challenge funding bodies. No disrespect to any funding body in the room. Love you. Probably have a love-hate relationship, but our focus is about health outcomes for our people. That's what will get us to the table. When you've got teams like Gunnu-maana who look at how can we work with our community control services, if they're not on the same page as us in health outcomes, then we wouldn't partner. Having Aboriginal people involved in universities breaks down this myth or this perception from community that research has always been bad for us. Yes, we have bad history, but that doesn't mean we can't have a great future. If we think positive about what people bring to the table that can result in a health outcome for our people, that's why we're invested in this program. Building our capability so we keep our families safe. We keep our women at home, our children at home, our men out of jails. That is what practising Aboriginal health is about.
I'd just like to add a little bit more because Jamie's done an amazing job about the interaction of the Aboriginal community controlled with Guunu-maana, but he's not tooting his horn enough. Like the thing with Aboriginal community controlled, it started from one little service in Redfern that was serviced by the local community, and there's now over 140 of them across Australia. It's the highest employer of Aboriginal health workers. It's an organisation that is run for the community, by the community, employs the community. So Jamie's saying, well, I don't really worry about what the community thinks about what the engagement is. It's because the community's in there. They're the fabric of these organisations. They do an unbelievably fantastic triage system, an opportunistic triage system. So John comes in with a sprained ankle and he's coming with mum and auntie. And so while they're all there, auntie gets her blood checked. Mum's like 3 months pregnant. Let's just do some antenatal care while you're here. Excuse me. So, it's a very opportunistic environment. Often it's the only Medicare organisation in country towns. So it's a huge battle between this, do we service the wider population or do we work for our community? It's an ongoing challenge. So there's so much about the Aboriginal community controlled health that doesn't get noticed. One of the things that I really want to flag for the innovation of AMSs, the very first global drive-through immunisation program happened from an Aboriginal health service in Parkes, which is a tiny little town, about an hour and a half from another moderately big town. And that was during H1N1, when swine flu was coming through. They did the first drive-through then. So, and it's a bloody global practice, or became one because of the pandemic, the incident. But they know what to do with the resources that they have. But as Aboriginal health workers, we work in multiple organisations, obviously primary health, in hospitals, in research centres, in doctors' services. So we primarily are there to help Aboriginal people navigate the health system with a culturally centred approach. So hospitals have a huge history of child removal, still have the capacity to do that now. So health workers are there to remind Aboriginal people that hospitals are not the place that you go to die. You know, they're actually places that can help fix you up. They also work between other clinical teams, social work teams, allied teams, to make it a lot easier. Oh, you're lovely. Oh, what's your name? Thank you, Harry. Oh, is Harry single? Any women in the world want a lovely man? That was so sweet of you. Oh, thank you very much. And so we as Aboriginal health workers, we unfortunately often get really crappy wages. We're not kind of, well, I shouldn't say we, but often a health worker is not acknowledged for the knowledge of country, the knowledge of culture, the historical knowledge that has come with them, having a lived experience as an Aboriginal person in an extremely racist country. Excuse me. We are there to kind of make that easier. We have had a history of being called when the bad things happen. Like, you have an elevated patient, so go calm them down. And, as a collective workforce, we're working really hard to be there for, right from the beginning, for the good stuff, for the challenging stuff, and also so that, not only do we keep a patient in hospital, but they're willing to also come back and make use of the clinical care that, is available to them. And one of the things that's getting a lot better is arranging for the primary healthcare setting to work alongside community controlled. So,
thank you both. Before we start opening it up as well, I just wanted to get your reflections on the importance of trust in partnerships. I think yesterday we heard a lot about the importance of trust, and we know that trust is such a determinant of health as well, particularly for Aboriginal and Torres Strait Islander people, and we'd just love to hear your reflections on its importance.
Number one. But you don't have trust unless you build a relationship. And I don't believe a relationship can be built on a CD-ROM or a half a day listen to a lecture on Aboriginal and Torres Strait Islander people. Build relationships with our people. We're not that scary. Well, some might be, but out in the country we're lovely people, mate. So we want to be able to build relationships. From relationships comes trust. If we don't have that relationship, then we'll never have trust. Because the trust that we build between each other is then delivered to our people. And guess what? Our people see it. When we're working with hospitals, then our people see that. We can talk about hospitals until the cows come home, but unless we're in a relationship with the hospital, then our people will still have a fear of going into hospital. We hear all the time about this discharging against medical advice. 80 to 90% of that is because of racism, not because of... You can't tell me that our people don't turn up at 10 o'clock at night at the hospital just to cause a problem. They're there to access healthcare, either for themselves or for their family. So why in the world would they discharge? Or why would they walk out? So there's one of the things that if we're going to trust working with mainstream systems and they trust us, the hard things have to be dealt with. Sometimes it has to be hard before it gets easy. But if you want health outcomes for the most vulnerable, which are my people, then build a relationship. Having Aboriginal people work within the universities is building that relationship. We don't know everything within our medical sector, and I'm sure these guys don't know everything about research within the university sector, but collectively we can know. That's what our people deserve. If they see us working at this level, then we engage a lot better at their level.
Can I jump in just very quickly on one thing you said, Jamie, which Jules will know?
Yep, I heard it.
Vulnerable people. It's a personal bugbear of mine, but it's also something that we try and really advocate hard for through Guunu-maana, that we aren't inherently vulnerable peoples. And I think, yesterday we heard about structural vulnerability, and I think we really need to just be thinking about the way that we shift language. And, rhetoric is so important, framing is so important. We aren't inherently vulnerable people. It's the systems in which we encounter that create vulnerabilities. And so I just wanted to just use this platform to point that out. Thanks.
Yes, you've got...
I'm an oncologist, and a sad fact that cancer is leading cause of mortality among the Aboriginal population within Victoria, overtaking heart disease and diabetes.
Could you just say the first bit, please?
I'm an oncologist, cancer specialist, and head of a department. I work at Eastern Health, and as you know, there's a large Aboriginal population within our catchment area. We're about to launch our First Nations Cancer Comprehensive Clinic at Hillsville, which is, connection to country and culture and family. And it's taken 4 years to liaise with our Aboriginal elders within our hospital setting and our Aboriginal liaison officers. And the clinic will run purely for Aboriginal patients, with culturally sensitive oncologists seeing patients with Aboriginal liaison officers and social workers concurrently, in tandem. Now, what advice would you give about building trust, and also, if anything that I might have forgotten, what are dotting the I's and crossing the T's?
One of the things, because trust comes from so many angles, my first introduction to trust was these guys. Actually, I spoke before about, you don't get paid correctly. Sorry, I obviously haven't had my HRT tap today. But I was recognised for what I could bring to the table. So I was given a decent wage. Then Guunu-maana, they set the scene for me. They had already spoken to my workforce and had set the ground rules about what they expected, the way that the hospital system would support me. I had an amazing Aboriginal manager. I worked in an Aboriginal health team, which so often Aboriginal health workers or Aboriginal liaison officers are left to wither by themselves without a supportive network, and they're seeing every patient that comes in. Just with the Children's Hospital, when I was the acute worker, I was on average seeing 22 children a day, and anywhere between 3 to 6 of them were in the last 24 hours. So I was trusted to do my job, but then I also trusted the people who were around me. So making sure that your Aboriginal liaison officers have a really good team that supports them. Guunu-maana came in and did the yarning sessions. They did the cultural competency safety yarning group that happened for like a year. So it was happening 8 months before I even came into the scene. So I didn't have to spend all my time educating those around me. So if you as a team could look to do some of that together, and not a one day or a weekend crash course. It's something that needs to happen over a period of time where you're bringing in the elements of the people that you're treating with and the people who come with them. I'm tooting my horn now. I collected the genotypes for HPV in Aboriginal populations in like 2009 or 2008. And we did that by going to Aboriginal communities around Australia and asking if we could take the pap smear brush and collect the cells off that. 85% of the women that we spoke to about that, they still believed that pap testing was a diagnostic tool, not a preventative tool. So if you want trust, have good health promotion. Like, that would be really singular. And don't think that someone's already heard of the information and now they're here and they're shivering in your room and you're thinking, well, they already know. Talk them through it every time they come to your room. Like, they take in so much information, like they need to trust you and feel like they can feel comfortable to remind you, oh, I don't understand what you said last week, or, you know, can we go over that again? So, and also ask for the trust of the funding bodies to know that when you're showing that you're doing a good job and the levels are coming down in your area, that the only reason they're going down is because you need to maintain this so it doesn't rise again. So your community will need to trust you to keep this as an ongoing project.
Thanks, Tophia. Just to add to that, I think it was really important, as Tophia said, and both Jamie and Tophia really honestly do not toot their horn enough. So I think what would really be beneficial is, which it has been for the burn services, is Tophia, so Aboriginal health workers, as Tophia said, roam around the hospital, look after so many different patients, but they're not centred in a certain service. So Tophia sits within the multidisciplinary team for the burn services, and so they trust her. Tophia trusts them. And because of that relationship, now Aboriginal and Torres Strait Islander families that come in also have that trust within the team. So Tophia's capabilities now with burns, and she's spoken of how she now knows a lot more about burns, she would not have had that opportunity staying as Aboriginal health workers around Australia. That's how they're working now. She would never have that opportunity. They would never have the opportunity of being able to build that trust within a multidisciplinary team. And the building capabilities and safeties program, it wasn't a ticker box. The nurses and doctors and receptionists and social workers and physiotherapists all did a program. It went for 12 months, and we had lots of great outcomes and a lot of good results for that. And we'll continue with that, and we do use it in a lot of different areas as well. But I think Aboriginal health worker 100% stays in that ward, knows the team, building cultural capabilities, not a ticker box, and make sure you've just got that communication going all the time. They deserve the recognition as Aboriginal health workers do.
Can I add two things to that? Is practicing reflective practice, so looking within, how are you working? The other thing is, three things. The other thing is, who is at the table as far as making decisions, resource allocation, who are you listening to? And the third is understanding what are your measures of success and whose knowledge are you basing that evidence on. So we absolutely need to rethink what constitutes evidence, whose voice is being centred.
Yeah. Also, in terms of that level of trust and who's knowing what, the training program for burns knowledge that happened in the Aboriginal Community-Controlled Health Services not only was a really in-depth workshop taken to the the AMSs, the Aboriginal Medical Services, clinical staff were brought back to the Kids Burns Unit, which is a comprehensive New South Wales paediatric burns unit. So all burns will get referred there, and then it depends whether it stays locally or whether they need to come in for dressing changes or grafting decisions. And when the clinical staff came to the AMSs, with the element of reflection, the nurses kind of said, like, we are so embarrassed because we were a bit nervous about these guys coming here and, we don't know really what an Aboriginal medical service is, and we don't know what their capacity or professionalism is. But, within, the first morning is like, this is what happens in the clinic, these are the patients come through. But by the third patient that's coming through, these Aboriginal health clinicians or community-controlled health clinicians are now being utilised to help out with the dressing changes. And then, and they're kind of like, it's more of a it's a more of a learning process than an information process. So that trust within the clinic that occurs because they know that they have witnessed that the Aboriginal staff know they're not Aboriginal staff, but they come from an Aboriginal organisation. Some are Aboriginal staff. That they have witnessed that they know how to assess the severity of a burn, that they know how to dress, and they know if they can actually follow them up for a few weeks before they come back to see if there's a grafting decision made or whether there's going to be scar management. And so that trust that goes back to community on a professional level is huge. And just to set the scene, prior to all this happening, I was called to go to the Kids Burns Clinic because they were concerned about a child because he's 7 years old and he was on an electric scooter without a helmet. So that's why he's in here. So they already got this idea of a neglectful situation. And so what had happened, Uncle had come over with his electric scooter. They're out the back having a cup of tea. 7-year-old goes, oh, yeah, I'm going to have a go at this. Like, it's a normal childhood event. So that was what was set up. So I go in. Mum's kind of like this against the wall. She's like this. And the boy is on the bench. And they were also doing a vacuum pack at this stage where they actually suck all the air out of the wound to make it like there's like a false skin on. So I was intrigued by that to start with. But then I was told that Mum's not engaged. So the 7-year-old is on the bed with an iPad. There's 4 clinicians around them. There's no room for Mum to be there. And I came and spoke to Mum and go, oh, hi, how's it going? She was like, oh, my God, I'm so tired. My 6-week-old had me up all night. They hadn't even spoken to Mum. So it went from them not knowing what to do with the black fella who's not really engaged to, oh, hi, my friend, how's it going? Yeah, come in. Oh, who else have you got at home? So the nurses are actually asking about who else is in the home setting, what's the kids been up to. They now understand that urban kids who have cousins and family in the country, where country kids have way more autonomy than the helicoptering that happens within the urban centres. And so it's not just the trust of the professionals with each other or the community with the setting. There's actually trust from the staff to the families. So.
Another question?
Is that okay? Or you?
Yeah, absolutely. Yeah. I was about to open it up, so that's perfect.
Oh, okay. My name's Michael Curtin. I'm from Charles Sturt University, and I just want to say a couple of things first before my question, and that is, Jamie, you are a legend as a CEO. Orange Medical Service is a really fantastic, Orange AMS, is a really fantastic service, and I just wish we could do more with you because it's quite inspirational. The other thing I'd like to say is Aboriginal health workers and community health workers overall, for me, are the mainstay of health in regional and rural areas and actually need to be better supported, because if we want to get health out to those areas. It's not about flying in doctors and allied health people. It's about supporting people in those communities to be more, to capacity build them. And I think that that's really important. It's nice to see that you're being acknowledged for the skills that you bring to the table, and I think a lot more. My question, Bud, is this is a fantastic relationship, and there's lots of great things that have come out, and I think I'll go away with trust as a determinant of health is my big learning from this session. How does this translate to other areas? Like I'm thinking of people with brain injury who get flown, people neurological impairments, or the many other, I guess, medical conditions that people get going from regional rural areas, go to the cities to be rehabilitated and then get flown back. So I guess I'm wanting to know about other areas where this is it translatable, is it transferable, and how does that work?
Well, actually, we have been, we've just put some funding in for the Heart Kids in Westmead, and Newcastle. So we're working with Westmead and Newcastle. We honestly believe that this model could work across any medical situation, whether it be brain injury, cardiac. And the cardiac's a little bit different because you've got children that are needing injections for many years. So that's going to be a really good test to be able to do safe pathways that way. And again, we will of course be working with community and hope for the same model. So don't take my model.
I think, yeah, or take it.
Oh, you can take it. Take the model. Yeah, take the model. But
I think so much of the work
give me some funding.
Yeah, we need funding. So much of the work that we do within Guunu-maana is disease agnostic, and so we're looking at models of care that can be kind of picked up and replicated in other areas, but obviously adapted as needed to the particular focus. But absolutely, I think something that we've developed in this could be replicated in other areas. Jamie?
There are models that are out there working now. What we don't do is open ourselves up to know what they are. The AMSs can't be everything to our people. We're just not equipped to do that. I mentioned earlier about navigating health systems. When we promote to our communities, we need to know what we're promoting. We just say we've got an oncologist, our people wouldn't care less. We say we've got a specialist in this and a specialist in that, they would not care. It's about a pathway. That's why we have names now, pathways. Navigation. My push, and I've said this to our local health district, we need to move away from calling our people liaison, because liaison is a completely misleading function what our people do. We should be calling them acute care navigators in our hospital systems. We've had liaison forever and a day. And depending where you are, it's what that position is not used for, abused for. You just can't have, especially in Orange, $300 million hospital, a training hospital, 2 Aboriginal liaison officers in a massive hospital like that. We have people being lost within the hospital systems. Hospitals do not work closely with Aboriginal medical services. My staff can't go into the hospital. A policy that negates trust. I'm not being nasty. The reality is that's what we're facing. We're talking about reforms. It's not about more money. It's about building relationships that leads to trust so that people see that in practice. Navigation of our hospitals is crucial for our people. If we have, where these guys are smart people, if this is the trend or the pattern of change in our communities, this is the illness and disease that's affecting us, whether heart disease, lung disease, whatever it is, then it's up to us to promote to our people that they are safe when they come to us about navigation and what the pathway is. We did a project called ARDAC, the kidney disease, tracking our people from when they were young kids right through. One of our nurses at work, her child was a part of that project. maintaining contact with our people. The only thing that's going to change Aboriginal health for us is constancy. You have to be constant in this. You can't fly in and fly out. That's never worked for us. Siloed healthcare is never going to get you health outcomes. If there's any doctors in the room, don't get offended by what I'm going to say next. 5-minute medicine doesn't work. Never has. A collective approach. We have at our service, we have 10 GPs who work for us, part-time. GPs want a life. So we provide that for them. GP-led, allied health-driven. Healthy ageing starts as soon as our baby is pregnant in mum. They age. That's when we should be applying healthy ageing, not when you're 50 or 60. We've got this whole health system back to front. How do we promote healthy ageing when we're saying when you're 50 we start engaging with you? Now people aren't reaching 50. Where's the madness in that? From conception all the way through. Tracking our people, connecting our people, building trust and relationships with our partners. That's how we get our people feeling safe. I mentioned to these guys the other day that I don't believe in cultural safety. Shock, horror in the room. Every person on this bench up here, or these seats here, are different. As Aboriginal and Torres Strait Islander people, we're different. We see things differently. We behave differently. So what do we have one term that encapsulates all of us? Wrong. From our young people at home, our young Aboriginal management in our organisation said they want to establish a culture of safety. What is the culture we're in? Healthcare, out-of-home care, aged care, care for people with disabilities. If we get that right, then our people will feel safe. The culture we're in is what our people need. I've never had in 20 years of running our organisation anybody ring me, any of my mob in my community ring me saying, do you have a black doctor available? Do you have a black dentist? Do you have a black psychologist? No, that's never happened. Our people want healthcare. If you walked into community and said, we are a culturally safe organisation or a culturally safe university, they would not know what you're talking about. Safety is where it doesn't matter who you are, where you are, what you're doing, it's the environment that you work in. So if you can make a culture of safety within your organisation, within your university, within wherever you are, right across this world, because this is a regional health across the world forum, we're in the culture of safety of healthcare. That's what attracts our people. That's what our people feel trust in. That's what works for us. It's different. If you've looked at the landscape in Aboriginal health for many, many years, we've had change in what is culturally safe. 18 months ago, 2 years ago, it was culturally safe and responsive. Now we're culturally safe. I can remember when it was cultural awareness, cultural appropriateness, cultural security, cultural integrity, cultural competence. Makes me vomit in my mouth. I am an Aboriginal person. I am not culturally competent. To say that is disrespectful. You can't say that you're culturally competent, culturally safe. I'm married to a non-Aboriginal woman. I'm still trying to work her out and she's still trying to work me out. We're not culturally competent. Doesn't mean we can't be culturally in a culture of safety though. We're all people. And majority of Aboriginal medical services in this whole country see all people. Because you know what? All people deserve to be treated with the definition of Aboriginal health. Not just their physical and emotional well-being, but their social, cultural, spiritual well-being. We're all different. If we embrace that and practice that, we'll get health outcomes for our people, not a problem.
I'm conscious that we had another question here. We are running out of time, so we'll just take this last question and then don't go on too long, panel.
I could be here all day.
Sorry, kia ora and warm personal greetings. I'm a researcher from One Connect, South Auckland, New Zealand, Aotearoa. My question is on research. To be honest, a lot of Western research methodologies don't work for Indigenous communities. So for all the researchers in the House, how important is to apply Indigenous methodologies to get the right evidence and results for all Indigenous communities, and especially within Australia in the setting today? Thank you.
100%, we definitely use Indigenous methodologies. We use methods when we're collecting data. I think it's really important to make sure that we're decolonising our research as well when we're out there talking to our families or communities or whatever. I think if we don't have that lens, that Indigenous lens throughout our whole research process, then we're not going to get all that really rich data that we really need to give to the funding bodies or the governments to say this is real. I know Indigenous research methodology is getting a lot more well known in the last 10 years, or maybe even 15 years now. A lot of people tend to think that Indigenous methodology is qualitative research. It's not. You have quantitative, you have qualitative, you have Indigenous methodologies, and I think there's that real big difference. And I think people, the more they learn about the Indigenous methodologies that we use in our research, and the rich data that we can collect, because it is decolonising and it is seeing through an Indigenous lens, I think we get a lot more richer data.
Yeah. Also, the workings of universities are changing dramatically. They're not there for the student anymore. They're there for, it's a business. And Aboriginal people, Indigenous First Nations people, our society is based on growing up, the children, knowledge transfer, handing over. Academia is, this is my knowledge, I'm going to keep it to myself until I find the right person to give it to, and then I'm going to get all the accolades. It's a very different approach. So one of the, we're collaborative. Where, in universities you need to be collaborative, but it's like you bring the money. Like so for people who are not First Nations people, really push against your schools about that and remind them that we do need to be changing the way that we deal with the community in terms of gaining knowledge, transfer knowledge.
I think also too, we've got to remember about data sovereignty. Yeah. So data sovereignty is when, like Jamie and the AMSs, if they're involved in that research, it's their research, it's their data. That's data sovereignty. Don't keep that data because it's not yours. It is actually the community's data. So I think we really have to be careful with that as well.
One of the main things that enables us to be involved in research, ultimately, is will this improve my practice? Is what we're going to learn through Guunu-maana or through ARDAC or through any other type of research, will this improve the practice of what we do? Will this deliver us health outcomes? Because in the relationship of trust, 50% of the time it's about research, 50% of the time it's about practice, health outcomes. That's what brings us to the table. What happened in the past was more 90% university, 10% community. That imbalance had to change if they want to be engaged with us. It's changed. Government will fund, will invest in evidence-based practice. That's where the relationship comes from. That's where the trust comes from. And you can have somebody at this table with 16 PhDs, but they don't know how we deliver that level of service to our people, then it's waste. So that's crucial when we talk about knowing, being and doing. If we don't know, then we can't be, and then we can't do.
We've come to the end of our session. Thank you so much for being such an engaged audience. If you have any other questions but weren't able to ask them here, please do feel free to come and find us afterwards.
And can you just stay a
Bring your
moment so we can
coffee.
take a photograph of all you in the
okay.
audience?
Sorry, just one thing. Just an FYI, as people are leaving, we've got an incredibly poorly timed press conference happening outside.
Oh, wow.
So just as you're leaving, if you could just be like a little quieter and just exit to the right stairs, if that's okay.
Okay.
Thank you.
We'll just take this
Go
one
ahead.
picture. And
Yeah,
then
take your time. You're fine.